Hi dear students, in today's class we'll be talking about NST and CTG, that is non-stress test and cardiotocograph. Now at the very onset I would like to tell that this is a very important topic because everybody in exam is asked about NST and CTG. These come as spotters also as well as in your table vivas. So first when you get a stretch like this, a stretch will come to you like this and then you have to identify. Okay, so this stretch has two sections in it, one the upper section and one is the lower section. The upper section tells about the fetal heart rate. So whatever is the fetal heart rate that is shown in the upper section, it will come like this, a fetal heart rate stretch. Whereas the lower section is about toco, that is the toco probe, that is the tocograph. Tocograph means, toco means contractions. So uterine contractions are shown in the lower graph. Okay, whenever there is contractions, it is shown. Now fetal heart rate is shown by a unit of beats per minute. Okay, so in 1 minute how many beats are there is the fetal heart rate, whereas tocograph is shown in the unit called Montevideo units. Okay, so it is calculated in Montevideo units. Now, whenever you are given a stretch in exam, try to see this tocograph is present or not. If the tocograph is not present or it is just baseline showing no contractions and only fetal heart is there, it means the patient is not in labor. In this case, the stretch will be a non-stress test because there is no stress and the patient is not in labor. Whereas when the tocograph is showing uterine contractions, then fetal heart rate is also there and contractions are also there, then it is a CTG, that is cardio, fetal heart, toco means contractions and graph. So it has both cardio and tocograph. Okay, so it is very important at the very onset when you see the stretch, try to find it whether it is an NST or a CTG. Okay, so first thing is this, to identify whether it is NST or CTG. Then once you have understood that it is NST or CTG, now we will go to its interpretation, how to read it. Okay, so at the very onset, first let me talk about the tocograph, that is the uterine contractions wala part, how to read this. Okay, so uterine contractions, suppose consider this, the graph which is below. Okay, uterine contractions will be shown when there are contractions, the probe will rise and then it will fall down. Okay, so it will show like this. Now at the very onset I would like to tell that if this is the mother's abdomen and this is the uterine height, suppose this is the uterine height, then where do we place the toco probe and where do we place the fetal heart rate probe? So the side where there is fetal back, consider this. Okay, this is the fetus and these are the limbs. This is a cephalic presentation. So the side where there is fetal back, that side we will estimate the spino-umbilical line. Spino-umbilical line is from the anterior superior iliac spine to the umbilicus. So we divide it into medial 2/3 and lateral 1/3, and that junction is for the fetal heart sound. So fetal heart sound probe is placed over there, whereas the toco probe is placed in the fundus of the abdomen, that is the highest part of the uterine fundus, there you place the toco probe. Now you will ask me why we place the toco probe in the fundus of the uterus. This is because the uterus has a pacemaker. Every organ that contracts on its own has a pacemaker where the contraction starts. So there are two pacemakers of the uterus. Both the pacemakers are at the two ostia, okay, or the cornua from where the fallopian tubes start. So this ostia, this pacemaker will start contractions which will go like this to the entire uterus, whereas this one will start contractions which will spread like this. Okay, so the point which gets maximum contractions fastest is the fundus of the uterus. So the toco probe is generally placed at the fundus of the uterus and the uterine contractions are measured. Okay, So as I have already told that uterine contractions are measured in a unit of Montevideo units. Now how do you calculate the Montevideo units? For that what you do is you will find that this is a graph which is showing values. Okay, there will be values like suppose it starts from 50, 60, 70, 80, 90, 100, like this it will go on. Okay, it will go on. So what you do is, what is the baseline uterine pressure that you measure? Suppose it is 50. 50 is the 50 millimeters of mercury is the baseline, and then the highest peak is at suppose 110. Okay, it is 110. So you subtract the highest minus the baseline. So it will be 110 minus 50, which is equal to 60. Okay. Now take a stretch of 10 minutes. Take a stretch of 10 minutes and see how many contractions are there. Suppose there are 6 contractions. Okay, so in all 6 contractions, subtract the highest minus the lowest pressures. Okay, so you get values. Suppose this was 60, some other was 55, some other was 58, some other is 50. So then you add all these with whatever is the resultant out of each contraction in 10 minutes and you get a value. Suppose you get 240. So what happens is, this is the Montevideo unit for this stretch of 10 minutes. So if the Montevideo units are more than 200, then the contractions are good enough for labor to progress. Okay, so for normal delivery to occur, the cumulative Montevideo units should be more than 200. Okay. Now regarding contractions, some of the important terminologies which I would like to tell is, contractions you measure for 10 minutes interval. Okay, so for 10 minutes how many contractions are there? If there are 3 or more contractions in 10 minutes, then it is called regular contraction. It is called regular contraction if it is 3 or more. If contractions are less than 3 contractions in 10 minutes, then you say it is occasional contractions. They are occasional contractions, they are not regular. And if there are no established contractions, there is only like this a little bit of irritability in the uterus, then this is called irritable uterus. Okay, so there are 3 terms based on the number of contractions. In 10 minutes, if there are 3 or more contractions, we tell it regular contractions. If it is less than 3 contractions in 10 minutes, we say occasional. And if there are no proper contraction, only a little bit of irritation in the uterus, then we say it is irritable uterus. But if contractions are more than 5, that is 6 or more contractions in 10 minutes, then you say it is tachysystole. It is tachysystole. So we generally do not want contractions more than 5 in 10 minutes, because tachysystole will lead to fetal distress. Because more the number of uterine contractions, more the time the uterus will be in contraction mode, and then fetal blood circulation will be reduced. So fetus will go into fetal distress. So what will you do if there is tachysystole? You have to give IV fluids to the patient, IV fluids, because tachysystole is a result of increased blood concentration of oxytocin. When the oxytocin amount level increases very much in blood, then the uterus keeps on contracting. Or if you have given very high dose of misoprostol or tinoprostone gel, if prostaglandins are given in very high amount, then also uterine contraction will rise. So in that case, you have to dilute the oxytocin level in the blood with IV fluids, and also give oxygen and left lateral position, so that patient's oxygen supply to the fetus increases. At the same time, I would also like to say that based on the intensity of contraction, contractions can be mild, moderate or severe. When do you say mild contraction? When one contraction is lasting for less than 20 seconds, then it is called mild contraction. When each contraction is lasting for 20 to 40 seconds, it is moderate contraction. Whereas if it is more than 60 seconds, it is called severe contraction. However, if the one contraction is more than 60 seconds, that is more than 1 minute, then it is called hyperstimulation. Hyperstimulation. Okay. So hyperstimulation is also a result of increased oxytocin or prostaglandins in the blood and can lead to fetal distress. So the treatment of hyperstimulation is also the same. Give a lot of IV fluids to dilute the oxygen in the blood. Give oxygen in left lateral position so that the baby is not landing up into hypoxia or fetal distress. So this is what we generally comment on contractions. Okay, so you have to tell, suppose this is a stretch whereby 10-minute stretch where there are 3 good contractions, then you say it is moderate to severe contractions and also regular contractions, because there are 3 contractions in 10 minutes. So you have to tell whether it is regular or occasional. You have to tell it is moderate to severe, or it is mild contraction, or it is irritable. You have to comment upon that. So this is all about contractions. Once you have told about contractions in CTG, then you go to the upper part of the graph, which tells about the fetal heart rate. In NST, of course, you will tell there are no contractions, and that is enough. So now we go to the upper part, which tells about the fetal heart rate. Okay. So fetal heart rate is never static. You will find it is not static. It is oscillating from one point to the other. Why it is so? This is because it is a dynamic equilibrium. It is a dynamic equilibrium between the sympathetic and the parasympathetic system. Sympathetic and parasympathetic system. Okay, sympathetic system. Okay, so that is why sometimes the sympathetic system takes over, sometimes the parasympathetic system takes over. So when the sympathetic system takes over, patient's heart rate increases, baby's heart rate increases and थोड़ा सा टैकीकार्डिया होता है. जब पैरासिम्पैथेटिक सिस्टम एक्टिवेट हो जाता है तो ब्रैडीकार्डिया होता है, फिर टैकीकार्डिया, फिर ब्रैडीकार्डिया, ऐसे करके हमारा साइकिल चलता रहता है. सो इन बेबीज where the sympathetic and parasympathetic system is not activated properly, there the heart rate will be almost a straight line. But in babies where sympathetic and parasympathetic system are well developed, there the variability will be high. So variability will be high. So it is very important to know whether variability is high or not, and that is most properly is better understood based on this your baby's maturity. So if there is hypoxia, if there is oxygen deficit, or there is hypoxia to the baby, hypoxia, in this case the first structure to be affected is your central nervous system, because central nervous system is very much dependent upon the oxygen content. So if central nervous system is gone, then the sympathetic and parasympathetic system will not be activated, and patient's variability of fetal heart rate will reduce and it will be a straight line. That is why variability is also an important feature. Okay, now whenever you see the fetal heart rate, there are 4 points on which you comment. Number 1, what is the baseline? What is the baseline fetal heart rate? So if you consider the graph, you find that, suppose this is the graph and this is the fetal heart rate. Okay, so the fetal heart rate should be constant for at least 2 minutes at one place to tell it is baseline. This is very important. So for 2 minutes, if fetal heart rate is oscillating around a certain fixed point, then it is called the baseline. Baseline, you tell whether if this is around 140 beats per minute, it is oscillating most of the time, then you say baseline is 140 beats per minute. Then comes your variability. Variability is how much is the variable nature of the fetal heart rate against the baseline. If this is the baseline, how much it is going up and down, how much it is going up and down will be the variability. Okay, so variability is also normal between 5 to 25 beats per minute. That is, at least 5 beats per minute it should go up and down every time. Each small square in the CTG trace or NST trace is of 5 beats per minute. So at least 1 square it should go up and down during the variability, during its normal course. Then comes acceleration. What do you mean by acceleration? If fetal heart rate increases by at least 15 beats per minute and it persists for 15 seconds, then you say it is acceleration. That is, it should rise by at least 3 squares, then it will be 15 beats per minute and it should last for at least 15 seconds. तुरंत उठ के कम हो जाता है तो उसको एक्सीलरेशन नहीं बोलेंगे. And fourthly, you have your deceleration. Deceleration is when the fetal heart rate decreases by 15 beats per minute and it is lasting for 15 seconds. Means it should decrease by at least 3 small squares and then it should last for 15 seconds, then it is called deceleration. So these are the 4 baseline variables, that is baseline, variability, acceleration and deceleration, which you should be commenting. So once you have talked about your baseline, variability, acceleration and deceleration, then you have to talk about the other parameters. So what are the other parameters that we talk about? This is a table which is very important and I will ask you to memorize this table. Memorize means if you go through the table again and again, then you will memorize it after all. So this table I am telling, we have baseline, we talk about baseline, variability, acceleration and deceleration. Okay. So basically the mnemonic by which I will ask you to remember is RNA. RNA means RNA, DNA, ribonucleic acid. So you can understand, you can remember it by the mnemonic RNA. So what does R stands for? R stands for reassuring. Okay, reassuring. N stands for non-reassuring. And A stands for abnormal. Okay, abnormal. So if everything is fine in the CTG or NST, then we say it is reassuring. If it is a bit abnormal, bit towards abnormal, then you say it is non-reassuring. और वो पूरा खराब होता है तो वो abnormal हो जाएगा. Now what is the normal baseline? Normal baseline fetal heart rate is between 110 to 160 beats per minute is normal. Okay, that is, it is called reassuring. Don't use the word normal, it will be reassuring. Okay, when the fetal heart rate baseline is between 100 to 110, that is, it has decreased by 10 or it has increased by 20, that is 160 to 180 beats per minute, then it is called non-reassuring. Whereas if it is less than 100 or more than 180, then it is abnormal. Okay. Coming to the next parameter, variability. When there is between 5 to 25 beats per minute, variability is said to be reassuring. If it is less than 5 for less than 50 minutes, then it is non-reassuring. Whereas if it is more than 25 for less than 25 minutes, then it is non-reassuring. At the same time, when it is less than 5 for more than 50 minutes, it is abnormal. Whereas more than 25 for more than 25 minutes, then it is abnormal. Okay. So now see, I'll tell you how to remember this. The duration will always be a 2-digit figure. It will be a 2-digit figure. So whenever you have 5 less than 5, to make it 2-digit, add a 0 to the right. So 5 के साथ 50 होता है. Whereas 25 is already a 2-digit figure, तो 25 के साथ हमेशा 25 ही होता है. ठीक है. Now see, when the variability is low, that is, it is less than 5, then we actually take a long stretch of CTG of 50 minutes duration. 50 minutes of duration ले लेते हैं. अगर first 50 minutes में मान लो variability कम था, variability was less, and you give IV fluids, oxygen, and then it gets corrected on its own after 50 minutes. So after 50 minutes, the variability is okay. It is not less than 5. Then it is non-reassuring. थोड़ा खराब है. लेकिन अगर 50 minutes के बाद भी इसका वेरिएबिलिटी कम ही चले जा रहा है एंड वेरिएबिलिटी इज नॉट पिकिंग अप, देन इट विल बी एबनॉर्मल. Similarly, when the variability is very high, more than 25 beats per minute, then take the stretch for 25 minutes. Take the stretch for the next 25 minutes. If it gets corrected by 25 minutes, okay, that is more than 25 was there for less than 25 minutes, then it is non-reassuring. Whereas it does not get corrected even after 25 minutes, then it is abnormal. ये खराब हो जाता है, ठीक है. Any kind of acceleration when it is present, it is always reassuring. Coming to deceleration, when there are no decelerations, then it is reassuring. When there are early decelerations, they are non-reassuring. Late decelerations are always abnormal. Coming to variable decelerations. Variable decelerations without concerning features are your non-reassuring features, whereas variable deceleration with concerning features will be your abnormal feature. Now at this same time, I would like to tell you what do you mean by early deceleration, variable deceleration, late deceleration, and what actually do you mean by concerning feature. Now see, whenever you have a deceleration, you find a deceleration, fetal heart rate has shown a dip, okay, it has shown a deceleration. Then always try to see if it is an NST, then you cannot tell whether it is early, late, or variable deceleration. Then you say it is only a deceleration present. But in case of a CTG, where contractions are already shown in the toco probe, there you try to compare what is the relation of the deceleration to the contractions. If every time you have a deceleration, at the same time you have a contraction, that is the peak of the contraction is coinciding with the nadir of the deceleration. The nadir is the deepest part of a valley. So nadir of the deceleration and the peak of the contraction are coinciding, then you say it is a early deceleration, because with every contraction, uterine contraction, the blood flow to the fetus decreases because uterine muscles are contracting. So when blood flow to the fetus is decreased, so at the same time the heart rate will decrease. So it is an early deceleration. The cause of early deceleration is fetal head compression. Now what do you mean by fetal head compression? In advanced labor, when the patient is almost fully dilated, then the head is engaged into the pelvis. Okay, head is engaged into the pelvis and head is just beside the cervix. So with every uterine contraction or lower uterine segment contraction, it is compressing upon the fetal head. And when fetal head is compressed, the 10th nerve or the vagus nerve is compressed beside the fetal head. When the vagus nerve is compressed, parasympathetic system is activated and there is deceleration or fetal heart rate decreases. So every contraction is coinciding with the fetal heart rate deceleration. So it is because of head compression, always remember, and it occurs in advanced labor. So what is your management? What will you do? You do a PV examination and try to look for whether patient is fully dilated or not. If she is fully dilated, shift the patient to delivery table, and prepare for normal vaginal delivery. It is never pathological. That is why I have told early deceleration is reassuring. ये अच्छा है, ये साइन है कि पेशेंट अभी नॉर्मल लेबर अभी डिलीवर हो जाएगी, पेशेंट ऑलमोस्ट फुल्ली डायलेटेड है. सो इसमें कुछ घबराना नहीं होता है अर्ली डिसेलरेशन. नेक्स्ट कम्स वेरिएबल डिसेलरेशन. Variable deceleration is there is no relation between the deceleration and the uterine contraction. Uterine contraction किसी भी टाइम आ जाएगा and deceleration भी किसी भी टाइम आ जाएगा. There is no relation between the deceleration and the uterine contraction. Then we say it is variable deceleration. Variable deceleration occurs because of umbilical cord compression. When there is umbilical cord compression, umbilical cord किसी भी टाइम compress हो सकता है. जैसे कि बच्चे के हाथ के नीचे दब गया कॉर्ड, बच्चे के बैक के नीचे दब गया, कहीं पे भी हेड के नीचे दब गया, तो ये सबसे कॉर्ड कंप्रेशन हो सकता है. Now cord compression is not at all pathological, but sometimes if the cord compression is occurring for a very long time, then it might be pathological, because cord compression हो जाएगा तो बच्चे में blood flow सही से नहीं होगा from the placenta to the baby, so oxygen supply will be hindered. So that is why whenever there is variable deceleration, you try to look for some features which are called concerning features. Now these are 5 concerning features which if present, then you say कि this variable deceleration is bad. But if these concerning features are not present, then the variable deceleration is not bad or worrisome. What are the 5 concerning features? Number 1, one deceleration. Okay, that is the variable deceleration. अगर one deceleration is lasting for more than 60 seconds, 1 मिनट से ज़्यादा एक डिसिलरेशन वेरिएबल डिसिलरेशन रह रहा है, then it is very worrisome, because फिर तो बेबी को हाइपोक्सिया हो जाएगा. Number 2, decreased variability within the deceleration. Decreased variability within the deceleration. Okay, within the deceleration. It means this is a deceleration, okay, and this is again a deceleration. But this deceleration is good because every time the sympathetic system is trying to overpower the parasympathetic system. But this is a bad deceleration because the sympathetic system is not working properly. So baby is hypoxic. Okay. The third feature which is there is W-shaped pattern. W-shaped pattern. It means that two decelerations are occurring one after the other at the same time. Okay, then it is called a W-shaped pattern. So it is bad feature or concerning feature. Number 4 is absence of shouldering. Absence of shouldering. Okay, now what do you mean by this? Shouldering means before and after each deceleration, generally there is a bit rise in the fetal heart rate, which is called shouldering. This is because sympathetic system always tries to overpower the parasympathetic system. So whenever there is a deceleration, heart rate उसके आगे and पीछे थोड़ा सा बढ़ जाएगा. So these are called shouldering. So shouldering is a good feature, but absence of shouldering is a concerning feature. Remember, absence of shouldering is a concerning feature. Number 5 is when inability to reach to baseline. Inability to reach to baseline. Okay, what do you mean? कि एक डिसिलरेशन आया है एंड डिसिलरेशन के बाद फीटल हार्ट रेट कभी नॉर्मल आया ही नहीं, then it is called inability to reach to baseline. If any of the 5, even 1 out of 5 or more than 1 out of 5 features are present, then you say that variable deceleration is having concerning features. So if concerning features are present, then it is an ominous feature and you say it is abnormal. Whereas variable deceleration without concerning feature will be not so much of worrisome, it will be in the middle category, that is non-reassuring. Okay, then we are left with late deceleration. What do you mean by late deceleration? Late deceleration means with every deceleration, when it comes, every deceleration comes after the uterine contraction. After the uterine contraction, बार बार uterine contractions जब खत्म हो जाएगा, उसके बाद nadir of the deceleration आएगा. Nadir of the deceleration will be after the contractions. Otherwise you can say the peak of the contraction is before the onset of the deceleration. So every time it is occurring, then it is late deceleration. Late deceleration occurs because of hypoxia. ओके, हाइपोक्सिया के चलते लेट डिसिलरेशन होता है. हाइपोक्सिया क्यों हो रहा है एंड उसके कारण लेट डिसिलरेशन क्यों होता है? रिमेंबर दिस hypothesis that whenever there is hypoxia, there is decrease in oxygen content in the body. But decrease in oxygen content is never a stimulus. It will lead to increase in carbon dioxide. We all know carbon dioxide accumulation, which is called hypercarbia. Now hypercarbia is always a stimulus for the chemoreceptors, and in our body when there is hypercarbia, our chemoreceptors are stimulated and we go for hyperventilation. But बच्चे तो hyperventilate नहीं करेंगे because lungs are collapsed and baby is in liquor. Okay, so hypercarbia will stimulate the chemoreceptors. The chemoreceptors will get stimulated and the chemoreceptors will increase the heart rate or the pulse rate of the baby. Okay, heart rate increase हो जाएगा. Whenever there is increase in heart rate, what body will try to do is heart rate increase हो जाएगा तो more and more blood supply होगा, more and more blood supply होगा mother से baby तक, तो ज़्यादा ऑक्सीजन आएगा. So that is why heart rate is increased by the chemoreceptors. Now increase in heart rate we all know is directly proportional to the systolic blood pressure. So systolic blood pressure increases, whereas I have already told earlier that diastolic blood pressure is dependent upon peripheral resistance. So that is why heart rate जब increase हुआ तो systolic blood pressure increase हो गया. Now this systolic blood pressure will stimulate the baroreceptors in the body and then baroreceptors will get activated. Baroreceptors are in the aortic arch, aortic sinus, carotid sinus, just near the 10th vagus nerve. So 10th vagus nerve or the 10th cranial nerve also gets stimulated, ठीक है, and because of which there is the vagus gets stimulated. Vagus gets stimulated will lead to decrease in heart rate, okay, because it has parasympathetic system. Now decrease in heart rate will be evident as a deceleration, okay, deceleration. So that is why, ठीक है, the entire cascade took time. That is why contractions के बाद, contractions में और ज़्यादा hypoxia हो जाएगा. अगर already hypoxia baseline है, उसके ऊपर से और contractions आ रहा है, uterus का blood supply कम हो जाएगा, then there will be more and more hypoxia and this vicious cascade takes on. So it takes a little bit of time. That is why it is a late deceleration. एंड देखोगे इससे पहले एक बार हार्ट रेट ट्रांजिएंट इंक्रीज भी हुआ था. दैट इज वाई एवरी डिसेलरेशन विल हैव अ शोल्डरिंग पैटर्न. दैट इज बिकॉज ऑफ दिस. ओके, शोल्डरिंग इज बिकॉज द हार्ट रेट वॉज इंक्रीज बिकॉज ऑफ chemoreceptors. So because of this entire cascade took time. That is why late deceleration, which is because of hypoxia, takes a bit of time and is ominous. So late deceleration is always bad, and that is why late deceleration we have categorized into abnormal. So now our table is complete. Baseline, variability, okay, and then acceleration and deceleration we have categorized it under reassuring, non-reassuring and abnormal. Now coming to our final interpretation. The final interpretation which we do is the final interpretation. When we write the final interpretation, we see how many parameter is where. So if we have all three are reassuring, it means baseline भी reassuring है, variability भी reassuring है and deceleration भी reassuring है. Acceleration of course will be reassuring. अगर तीनों reassuring है then we tell the final interpretation, final CTG या फिर NST is normal. Okay, it is normal. But if one is non-reassuring, that is in the second row, and बाकी दोनों reassuring है, then हम बोलेंगे कि it is a suspicious CTG. It is a suspicious CTG. But if any one अगर abnormal category में चला जाता है, third category में चला जाता है, irrespective of what the other two is, ठीक है, एक भी abnormal हो जाता है और दो नॉन reassuring हैं एंड एक reassuring है, अगर ऐसे भी होता है then we will say it is pathological CTG. Pathological CTG. Okay. So in normal CTG, what is your management? You have to just reassure the mother and wait for normal vaginal delivery. Whereas in suspicious CTG, give IV fluids, oxygen and left lateral position, and then talk to the mother that now our CTG is not bad but it might progress to bad, so you take consent कि there might be need for early delivery, but at this same time you will give IV fluids, oxygen, left lateral position and do a pervaginal examination and see what is the dilatation. But in pathological CTG you have to do urgent delivery. It will be an emergency delivery has to be conducted. So what you do is, at the very first onset you will give IV fluids, ऑक्सीजन एंड लेफ्ट लैटरल पोजीशन तो करेंगे ही, इसके साथ साथ यू डू अ PV एग्जामिनेशन एंड यू ट्राई टू सी कि डायलिटेशन ठीक ठाक है कि नहीं. इफ डायलिटेशन इज मोर देन 8 centimeters और ऑलमोस्ट शी इज फुल्ली डायलेटेड, in this case you go for instrumental vaginal delivery with forceps and ventouse and try to deliver very fast. Otherwise, if the patient is in early labor and patient's dilatation बहुत कम है, patient is not fully dilated, then you have to go for a lower segment cesarean section, emergency cesarean section, to save the baby. So this is what is about NST and CTG. I hope you have understood. If any doubt, you can let me know in the comment section, and any problem anywhere, you can contact me anytime. So for more information, remain subscribed to my channel and look up for the classes every Tuesday and Friday. Thank you so much.